Every 66 seconds, another senior in this country is told they have dementia. By the time you finish reading this, 20 more families will have heard those words. And for some of them, the cause was never their age. It was a bottle sitting on the bathroom shelf that they were promised was safe. A medication that a doctor prescribed and a pharmacy filled without a single warning about what it could do to their memory. Here is what the newer research keeps showing, and it is something that should concern every person over 60 who takes daily medication. One ordinary, everyday class of drugs can pull your memory and your learning down hard inside a single year, and most people taking them have absolutely no idea it is happening. They blame age. Their families blame age. Even their doctors sometimes blame age. But the real cause is chemical, and it is reversible if you catch it in time. These drugs are called anticholinergics, and that long word hides a simple idea. They block a brain chemical called acetylcholine. Acetylcholine is the messenger your brain relies on to lay down a new memory, to stay alert through the day, and to connect one thought to the next in a clear, logical chain. It is the chemical that lets you remember a name you just heard, recall where you put your keys, and follow a conversation without losing the thread halfway through. Currently, an estimated 6.7 million Americans aged 65 and older are living with dementia, and researchers believe that a significant percentage of those cases involve medications as either a direct cause or a contributing factor. As we age, the brain naturally produces less acetylcholine and leans harder on every molecule it has left. So when a drug blocks what little remains, the impact lands far heavier on a 7-0-year-old brain than it ever would on a 3-0-year-old one. The part that takes the hardest hit is the hippocampus, the small seahorse-shaped structure deep in your brain where new memories are formed before they get filed away for long-term storage. Today, we are counting down 9 medications most closely tied to rapid memory loss, from the ones that get quietly overlooked to the one I consider the most destructive of all. Watch for number 3 because it is handed to millions of seniors for something that sounds completely harmless, and it may be shrinking the memory centers of your brain right now without a single warning sign. Number 9 is diphenhydramine. You know it by its drugstore name, Benadryl. It is the little pink pill people reach for to fall asleep, to calm an allergy, to take the edge off a cold. It costs a few dollars. It sits on an open shelf next to the toothpaste and the shampoo, and most people assume that because nobody needs a prescription for it, it must be gentle. Inside your brain, it is doing something very different. Benadryl is an anticholinergic. It blocks acetylcholine, that memory chemical we just talked about, and it does so aggressively. Every time you take it, the hippocampus where your new memories are formed gets quieted down. For a younger brain with plenty of acetylcholine to spare, that dip is temporary and barely noticeable. For an aging brain that is already running low, that same dip can mean the difference between a sharp evening and a foggy one, between remembering a grandchild's birthday and drawing a blank at the dinner table. The research connects it plainly. A 2023 paper in the Journal of Geriatric Cognitive Health followed older adults who used anticholinergic drugs regularly and found a 54% higher risk of developing dementia compared with people who stayed off them. More than half again the normal risk from something most of us treat like candy. And the danger does not stop at the Benadryl bottle, because this same compound hides inside dozens of other products. Anything labeled PM, nighttime formula, or sleep aid on the pharmacy shelf is very often just diphenhydramine wearing a different name. Studies estimate that over 20% of adults over 65 use at least one over-the-counter product containing diphenhydramine on a regular basis, without realizing they are taking an anticholinergic drug. If you take it for allergies, there are newer antihistamines like loratadine that do not cross into the brain the way diphenhydramine does. They control the sneezing and the itching without touching your memory centers. If you take it for sleep, that is a conversation worth having with your doctor because there are safer paths to a good night's rest that do not cost you clarity the next morning. Never stop a medication on your own, but stop assuming that over-the-counter means safe for your memory, because that assumption is one of the most dangerous ones a person over 60 can make. Number 8 is one your stomach loves and your brain quietly pays for. The proton pump inhibitors. The big names are omeprazole and esomeprazole, and chances are you or someone you know has been taking one of them for years. These drugs shut down acid production in the stomach, and they get prescribed for heartburn, acid reflux, and that burning feeling after meals. People stay on them for years, sometimes decades, because the moment they stop, the symptoms come roaring back. So the pill feels like the only thing holding the line between comfort and misery. Here is the part almost nobody hears at the pharmacy counter. Your stomach needs acid to pull certain critical nutrients out of your food, and chief among them is vitamin B12. B12 protects the wiring of your nerves and your brain. It is essential for maintaining the myelin sheath that insulates every nerve fiber and allows signals to travel cleanly and quickly. Turn the acid down far enough, long enough, and your B12 quietly drops. So, do magnesium and calcium, two minerals your brain cells depend on to fire properly and communicate with each other. Research shows that approximately 20 to 30% of long-term PPI users develop measurable B12 deficiency, and that number climbs higher in adults over 65 whose absorption capacity is already declining with age. Starve the neurons of those nutrients, and you get misfires, confusion, and memory slips that look exactly like early dementia, when the real cause is a nutritional deficit your medication has been creating all along. In 2016, a large study published in JAMA Neurology examined more than 73,000 people aged 75 and older. Regular PPI users had a 44% higher risk of dementia than people who did not take them. And the trouble runs deeper than nutrients, because PPIs have also been shown to raise levels of amyloid beta in the brain, the sticky protein that builds up in Alzheimer's disease and forms the plaques that destroy neural connections. So, you are not just blocking nutrient absorption. You may be actively contributing to the very brain pathology that defines the most feared disease of aging. If you take a PPI every single day, that is a conversation to have with your doctor at your next appointment. Many people can taper down onto a gentler class of acid reducers called H2 blockers, like famotidine, which is far less likely to interfere with nutrient absorption or touch your thinking. Dietary changes can also make a significant difference. Eating smaller meals, avoiding food within 3 hours of bedtime, and reducing caffeine and alcohol can cut reflux symptoms substantially without any medication at all. The goal is the lowest effective dose for the shortest necessary time, not a pill you take forever out of habit because nobody ever told you to stop. Number 7 is prescribed for a problem most people would rather not talk about: the bladder drugs, and the one to know by name is oxybutynin. It is given to seniors who deal with a sudden, urgent need to get to the bathroom, the kind of overactive bladder that can reshape an entire day around knowing where the nearest restroom is. The relief it provides is real, and the embarrassment it spares people is real too. No one wants to worry about an accident at the grocery store or during a family dinner, but oxybutynin works by blocking acetylcholine, the same memory chemical that Benadryl blocks, and it does so with alarming efficiency. Unlike some drugs that stay mostly in the body and only trickle into the brain, oxybutynin slips across the blood-brain barrier very easily and parks itself right where memories are made. That makes it one of the more dangerous medications on this list for an older adult, especially when taken month after month, year after year, which is exactly how most people use it. In 2019, the British Medical Journal published a study of people over 65 who took strong anticholinergic drugs like oxybutynin for more than a year. Their risk of dementia was 49% higher, close to 1 in 2. And here is what troubles me most about that number. Almost none of those patients were warned. They were told a pill would calm their bladder. Nobody mentioned it might be dimming their mind at the same time. The fog gets blamed on age. People describe forgetting appointments, losing their keys 10 times a day, dropping the thread of a simple conversation, and everyone around them nods and says you are just getting older. It is rarely traced back to the prescription, until real ground has already been lost. Currently, an estimated 33 million adults in the United States deal with overactive bladder symptoms, and oxybutynin remains one of the most commonly prescribed first-line treatments, despite its known cognitive risks. If you take oxybutynin and you have noticed your memory slipping, take that seriously because you do not have to choose between your bladder and your brain. Newer medications like mirabegron work through a completely different pathway. They relax the bladder muscle without touching acetylcholine at all, which means they give you the same urinary control with far less risk to your thinking and your memory. Pelvic floor exercises, timed voiding schedules, and reducing caffeine and alcohol intake can also reduce urgency significantly without any medication. Bring it up at your next visit. Number 6 might be the most surprising entry on this list because it is one of the most prescribed drugs on Earth: statins. The names you would recognize are simvastatin and atorvastatin, and they are among the most widely prescribed medications in the world, especially after age 60. They do an important job lowering cholesterol and cutting the risk of heart attacks and strokes, and they belong in a lot of people's lives. This is not a case against statins, and I want to be very clear about that. What follows is the half of the story that usually gets left out of the conversation. Cholesterol does far more in your body than affect your heart. Your brain is close to 60% fat by dry weight, making it the fattiest organ in your entire body. It uses cholesterol to build something called the myelin sheath, the insulation wrapped around every nerve fiber so that electrical signals travel fast and clean from one neuron to the next. Think of myelin like the rubber coating around an electrical wire. Without enough of it, signals leak, slow down, and misfire. Lower cholesterol hard enough with a strong enough statin, and you can leave the brain short of a raw material it genuinely needs to maintain those connections. In 2023, a study in Frontiers in Aging Neuroscience found that adults over 70 who had been on statins for more than 3 years had a 26% higher rate of mild cognitive impairment, and the higher the dose, the steeper the slide. Some patients described frightening blanks, a familiar name gone completely, a conversation they had just finished erased from memory minutes later, a route they had driven for 20 years suddenly unfamiliar, as if they had never been on it before. The World Health Organization estimates that cardiovascular disease kills approximately 17.9 million people per year globally, which is why statins are prescribed so aggressively. But the cognitive cost in older adults deserves to be part of that conversation, not swept aside. The important thing to understand is that not every statin touches the brain the same way. The statins that cause the most trouble are lipophilic, meaning they dissolve in fat and cross into brain tissue easily. Simvastatin and atorvastatin fall into that category. Pravastatin and rosuvastatin are hydrophilic, meaning they stay mostly in the bloodstream and do not penetrate the brain as readily. They are generally considered the safer choices for preserving cognitive function while still protecting the heart. So, if you have been on a statin for years, and you are noticing fog, forgetfulness, or confusion creeping in, that is a real conversation to have with your doctor about switching to a hydrophilic option or adjusting the dose. It is never a reason to quietly stop taking a medication that may be protecting you from a heart attack or stroke. Get the plan right with medical guidance, never on your own. Number 5 is the benzodiazepines. Lorazepam, sold as Ativan; diazepam, sold as Valium; alprazolam, sold as Xanax. These are among the most prescribed drugs in the world for anxiety and for sleep, and they work by boosting a brain chemical called GABA. GABA is your brain's own calming signal, the one that turns down a racing, overstimulated nervous system and lets everything slow to a manageable pace. At first, they feel like a rescue. The panic eases, the spinning thoughts stop, sleep finally comes after nights of lying awake staring at the ceiling. For someone who has been suffering, that relief feels like a miracle. Over time, the picture changes completely. What starts as a rescue slowly becomes a trap. A 2022 study in the British Medical Journal followed more than 8,000 seniors for 6 years and found that those who used benzodiazepines for longer than 3 months had a 51% higher risk of Alzheimer's disease. Not dementia in general, Alzheimer's specifically, the most devastating and irreversible form. The longer-acting types like diazepam were worse because they linger in the body far longer than people realize. The half-life of diazepam in an older adult can stretch to 100 hours or more, meaning a single pill taken on Monday night is still sedating the brain on Thursday. It builds up in fatty tissue, including the brain itself, and with daily use, the drug never fully clears before the next dose arrives. What the drug is doing is not calming one small area of the brain. It is sedating the entire organ. The brain learns new things more slowly. It grows less flexible, less able to adapt, less able to form and retrieve memories. Many people describe a flatness, a sense of moving through thick fog, of not quite being themselves anymore, but not being able to pinpoint exactly what changed. Studies estimate that approximately 12% of adults over 65 are currently taking a benzodiazepine, and nearly half of those have been on one for longer than the recommended short-term window of 2 to 4 weeks. The cruelest part of benzodiazepines is the exit. Stop one abruptly after weeks or months of use, and the anxiety and insomnia come roaring back twice as hard as they were before you started. The rebound is so intense that it can include agitation, tremors, seizures, and in rare cases, life-threatening complications. That violent rebound makes the pill feel absolutely essential right at the moment when it is doing the most harm. The patient believes they cannot survive without it because the withdrawal has made everything worse, and so they keep taking it, and the cognitive cost keeps climbing. So here is the rule, and it matters more than almost anything else in this video. If you have been on a benzodiazepine for more than a few weeks, do not stop suddenly, because abrupt withdrawal can be genuinely life-threatening. Work with your doctor to taper down slowly over weeks or months, reducing the dose in small increments that give your brain time to readjust. A safe taper might take 3 months, 6 months, sometimes longer for people who have been on high doses for years. Patience during that process is not weakness. It is the medically correct approach. Gentler options exist and they work. Buspirone is an anxiety medication that does not sedate the brain, does not build dependence, and does not carry the same cognitive risk. For insomnia, cognitive behavioral therapy specifically designed for sleep, known as CBTI, has been shown in clinical trials to be more effective than benzodiazepines for long-term sleep improvement without any of the cognitive cost. A 2016 study from the American College of Physicians found that CBTI produced better sustained sleep outcomes after 12 months than any sleep medication, with zero risk to memory or brain function. The calm you are looking for does not have to come at the price of your mind. Number 4 is a single pill prescribed for 3 different problems, and it carries one of the heaviest hidden burdens of all: amitriptyline. It is an older antidepressant from a class called tricyclics that was first developed decades ago, yet it is still handed out today for nerve pain, for sleep, and even to prevent migraines. That versatility is exactly why it spread so quietly into so many medicine cabinets. It looks like a do-everything pill, the kind of convenient solution that busy doctors reach for when a patient has multiple complaints and they want one prescription to cover several problems at once. Underneath that convenience is one of the most powerful anticholinergic drugs still in wide use. Amitriptyline blocks acetylcholine harder than almost any other medication commonly prescribed to older adults. It does not just reduce the chemical slightly, it suppresses it so aggressively that with long-term use, the effect on memory stops being a rare side effect listed in fine print and becomes the expected result. Your neurons need acetylcholine to talk to each other and to lock in new memories. Strip that chemical away night after night, year after year, and the communication network that holds your thinking together begins to thin. In 2015, a large study published in JAMA Internal Medicine followed more than 3,400 adults aged 65 and older for over a decade. Those with the highest cumulative dose of anticholinergic drugs, like amitriptyline over 10 years, had a 54% greater chance of developing dementia. More than half again the normal risk, and almost none of them were ever told the pill could do that. They received it for sleep or for nerve pain, then slowly noticed words going missing, memory thinning, concentration fraying at the edges, and they chalked every bit of it up to getting older. Their families did the same. Even their doctors often did the same. It does not even take a high dose to cause damage. A small nightly dose of 10 or 25 milligrams taken consistently for years can quietly erode cognitive function with no obvious dramatic symptom until the accumulated loss becomes impossible to ignore. Research suggests that the anticholinergic burden is cumulative, meaning every dose adds to a running total that your brain carries forward. The damage is not like a bruise that heals when you stop. It is more like erosion on a hillside. Each small rain does little on its own, but over years the landscape changes in ways that are very difficult to reverse. If you or someone you love takes amitriptyline, that is a conversation worth having soon. Not in 6 months, not at the next annual physical, but soon. For nerve pain, alternatives like duloxetine or gabapentin can provide similar relief without the same anticholinergic weight pressing down on the brain. For sleep, low-dose melatonin or a very small dose of doxepin, which is far gentler on the acetylcholine system, can take its place. For mood, newer antidepressants like sertraline or escitalopram are considered much safer for the long-term health of an aging brain. The goal is not to suffer without treatment. The goal is to find treatment that does not quietly steal something precious while pretending to help. Number 3 is the one I told you to watch for at the very beginning because it is handed to millions of people for something that sounds completely harmless, and its cognitive cost hides behind a reputation it does not deserve. Paroxetine. It is one of the most prescribed members of a family of antidepressants called SSRIs, used widely for depression and anxiety. And on the surface, it looks like the modern, gentle option, the kinder alternative to the older psychiatric drugs like amitriptyline that we just covered. Patients feel reassured when they hear SSRI because the class has a reputation for being well tolerated and safe. For most SSRIs, that reputation is earned. For paroxetine, it is dangerously misleading. Here is the detail that rarely gets mentioned. Paroxetine is the one SSRI with significant anticholinergic activity. That single fact sets it apart from its siblings like sertraline and escitalopram, which are genuinely gentle on the acetylcholine system. Paroxetine reaches into the same chemical pathway that every other drug on this list has been chipping away at. It blocks the same memory messenger, suppresses the same hippocampal function, and over time it wears down the same cognitive abilities that patients and families are desperately trying to protect. In 2021, a large review published in Frontiers in Psychiatry looked at older adults taking different SSRIs and found that paroxetine users showed measurable drops in short-term memory, word recall, and sustained attention within the first 12 months of use. Seniors on paroxetine were 30% more likely to show early signs of cognitive impairment than those taking other antidepressants in the same class. That gap is not subtle, and it is not ambiguous. It is a clear signal that this particular drug behaves differently inside an aging brain despite wearing the same SSRI label as its safer relatives. There is a hard irony in that, because the drug is given to steady the mind, to lift the fog of depression, to bring back clarity and engagement with life, and over time it can wear down the very clarity it was prescribed to protect. A person takes it for depression, feels somewhat better emotionally, but slowly notices they cannot find the right word in conversation, cannot remember what they read an hour ago, cannot follow the plot of a television show they have watched for years. They assume the depression is getting worse or that aging is accelerating, when the cause is sitting in the pill bottle on their nightstand. The fix here is clear and well documented. In older adults, paroxetine is one to avoid. The American Geriatric Society placed it on something called the Beers List, which is a formal, regularly updated catalog of drugs considered potentially inappropriate and risky for seniors. Paroxetine is on that list for exactly the cognitive reasons we are discussing. If you take paroxetine, ask your doctor about transitioning to a safer SSRI, like sertraline or escitalopram, both of which treat depression and anxiety effectively without carrying the same anticholinergic burden. The switch should always be managed by your prescribing doctor because stopping paroxetine abruptly can cause withdrawal symptoms including dizziness, irritability, and a sensation patients describe as brain zaps, brief electrical jolts that are harmless but deeply unsettling. A gradual taper over several weeks makes the transition smooth and comfortable. Supporting your B vitamins during the process, especially B12 and B6, can help steady mood naturally alongside the medication change. Number 2 is so quietly prescribed that many people taking it have no idea what kind of drug it even is: the antipsychotics. And this one disturbs me deeply because so many of the people taking them never agreed to take an antipsychotic in the first place. The names are quetiapine, risperidone, and olanzapine. These are powerful psychiatric medications that were originally built and approved for serious mental illness like schizophrenia and bipolar disorder, conditions where the brain's chemistry is so severely disrupted that strong intervention is genuinely necessary. Those are legitimate uses, and in those contexts, these drugs can be life-saving, but that is not how millions of older adults end up on them. Today, these same drugs get handed out off-label to seniors for sleep problems, for mild restlessness, for the agitation and confusion that can come with early dementia itself. In nursing facilities and assisted living centers across the country, antipsychotics are used to manage residents who wander at night, who become agitated during care routines, who ask the same question repeatedly, or who simply become difficult for an overworked, understaffed team to manage. An estimated 21% of nursing home residents in the United States receive antipsychotic medications, and independent reviews have found that in many cases, there is no documented psychiatric diagnosis justifying their use. Powerful drugs designed for severe psychiatric illness are being used as chemical restraints on seniors who are simply confused, restless, or inconvenient. The cognitive cost is devastating. In 2022, a study published in Lancet Healthy Longevity followed more than 25,000 older adults and found that those given antipsychotics for behavioral symptoms were 71% more likely to suffer worsening cognitive decline within a single year, even when they had no prior history of dementia before the medication was started. That is not a gradual erosion over a decade. That is a steep, measurable drop in brain function within 12 months. Some of these patients were given the drug for something as minor as difficulty sleeping or occasional agitation, and within a year, their thinking had deteriorated to a degree that looked like advancing dementia on every standard test. These drugs work by suppressing dopamine, a brain chemical tied not only to mood and motivation, but also to focus, planning, working memory, and the ability to process new information. Dopamine is what gives your thinking its sharpness, its speed, its sense of engagement with the world around you. Drop dopamine far enough, and the brain goes slow, dull, and unresponsive. That is why people on these medications can seem flat, absent, disconnected, as if the person inside has gone quiet. Their families watch this happen and grieve someone who is still sitting right in front of them, believing that the disease is progressing when the cause is pharmaceutical. The risks extend well beyond cognition. Antipsychotics in older adults raise the risk of stroke by an estimated 30 to 50%, depending on the specific drug and the duration of use. They increase the risk of sudden cardiac death. They cause the kind of heavy sedation that leads to falls. And falls in adults over 65 are the leading cause of injury-related death, killing approximately 36,000 older Americans every year, according to the Centers for Disease Control. A medication that makes a person drowsy and unsteady in a population already vulnerable to falls is not just a cognitive risk. It is a physical danger that can end a life with a single misstep on a staircase or a bathroom floor. If you or a loved one is currently taking one of these medications, the first move is to ask the prescribing doctor a direct and honest question. Why was this drug started? And is it truly necessary for a diagnosed psychiatric condition? Or is it here for behavioral convenience? That question alone can change the entire trajectory of care. Most behavioral symptoms in older adults, the restlessness, the nighttime wandering, the agitation, can be eased without a drug at all. Steady daily routines give the brain predictability that reduces confusion. Less noise and overstimulation in the environment calms agitation more effectively than sedation. Treating hidden pain, which is one of the most common and most overlooked triggers of behavioral disturbance in older adults, often resolves the very symptoms the antipsychotic was prescribed to suppress. Fixing lighting and sleep environments can dramatically improve nighttime restlessness. When medication truly is necessary for a genuine psychiatric diagnosis, the principle is the lowest possible dose for the shortest possible time, with regular reassessment to determine whether the drug is still needed. Far too often, an antipsychotic gets started during a hospital stay or a particularly difficult week, and then nobody ever revisits the decision. The prescription just continues, month after month, year after year, quietly suppressing the brain, while everyone assumes the decline is natural aging. It is not always natural. Sometimes it is chemical, and the only way to find out is to ask the question. Number one is not a single drug at all, and it may be the biggest hidden driver of every story I just told you. Anticholinergic polypharmacy. It is the danger almost nobody names, and it may be one of the largest causes of drug-induced memory loss in older adults alive today. You were probably waiting for one final villain, a single worst pill to avoid. The real worst case is something far more subtle and far more common. It is the slow, invisible stacking effect of taking several anticholinergic drugs at the same time, with nobody adding up the total burden they place on your brain. Polypharmacy simply means taking many medications at once, and among adults over 65, it is extraordinarily common. Research shows that approximately 40% of older adults in the United States take 5 or more prescription medications daily, and nearly 20% take 10 or more. When several of those medications happen to carry anticholinergic properties, the combined weight of all of them blocking that one memory chemical together creates a burden far greater than any single drug would produce on its own. Picture a very common situation. A senior takes diphenhydramine every night to fall asleep. She takes oxybutynin every morning for her overactive bladder, and she takes amitriptyline at bedtime for the nerve pain in her legs. Each one alone might cause only a small, barely noticeable dip in acetylcholine. Her doctor might look at any single prescription and say the cognitive risk is minimal, but she is not taking one. She is taking 3. And together they are hitting the same chemical target from 3 different directions simultaneously. The total suppression of acetylcholine in her brain is not the sum of 3 small dips. It compounds because each drug removes a layer of protection that was helping compensate for the others. In 2022, a study published in Age and Aging tracked more than 280,000 older adults over a decade and found that those with the highest anticholinergic burden had a 120% higher risk of dementia within 10 years, more than double the normal risk, not from one dangerous drug. From the quiet accumulation of several seemingly harmless ones prescribed by different doctors who never communicated with each other about the total load. One doctor prescribed the sleep aid, another prescribed the bladder medication, a third prescribed the pain pill. Each one made a reasonable individual decision. Nobody added up the bill, and the great majority of those 280,000 people had no idea they were even on anticholinergic drugs at all. Nobody had ever used that word with them. Nobody had ever explained that their sleep pill and their bladder pill and their pain pill were all reaching into the same chemical system and pulling the same lever. They just knew they were taking their medications as prescribed, and their memory was getting worse. And they assumed that was simply what aging looked like. When you block acetylcholine from several directions at once, the brain does not just slow down temporarily and bounce back when you stop. Neurons that go unstimulated for long enough begin to wither from disuse. Synaptic connections shrink. The dendritic branches that allow one neuron to communicate with thousands of others start to retract. The brain settles into a quiet, underpowered state that looks almost identical to Alzheimer's disease on standard cognitive testing. A neurologist examining a patient with severe anticholinergic burden and a patient with genuine early Alzheimer's would have difficulty telling the two apart based on symptoms alone. The memory gaps are the same. The confusion is the same. The difficulty finding words, the blank stares, the loss of orientation, all of it overlaps almost perfectly. Here is the hopeful part, and it is the reason I wanted this to be number one. Drug-induced cognitive decline is often reversible when it is caught early enough. That is what separates it from true Alzheimer's disease and makes it simultaneously the most tragic and the most preventable form of memory loss in older adults. Tragic because millions of people are living with diminished minds right now from medications they could stop or switch. Preventable because the fix does not require a breakthrough drug, an experimental therapy, or a miracle. It requires a careful conversation and a piece of paper. Lift the anticholinergic burden, and many people get their clarity back. Their energy returns, their memory sharpens, their personality reemerges. Studies have documented measurable cognitive improvement within weeks to months of reducing anticholinergic load in older adults. The brain is more resilient than we give it credit for, but only if you identify what is hurting it and take that pressure away. The fix does not take a miracle. It takes a comprehensive medication review. Sit down with your doctor or your pharmacist and have them go through every single prescription, every over-the-counter pill, every supplement, and every nighttime sleep aid, and add up the total anticholinergic load using one of the validated scoring tools that exist for exactly this purpose. The Anticholinergic Cognitive Burden Scale and the Anticholinergic Risk Scale are both widely available and simple to use. Any pharmacist can run through your medication list and give you a score within minutes. Once the problem drugs are identified, you work with your doctor to taper off what you no longer need, switch to safer alternatives for what you do still need, and give the brain room to recover and rebuild. This is the most preventable threat to the aging mind on this entire list, and that is exactly why it sits at number one. Not because it is the most dramatic, because it is the most common, the most overlooked, and the most fixable. So let me tell you what to do this week. Because knowledge without action changes nothing. First, gather every medication you take, every single one, including the over-the-counter pills you buy yourself, the allergy tablets, the sleep aids, the antacids, everything. Put them all on the kitchen table where you can see the full picture for the first time. Second, take that collection to your next doctor appointment or walk into your pharmacy and ask for an anticholinergic burden review. Use those exact words. Any good pharmacist will know exactly what you mean and will be glad you asked. Third, do not stop any medication on your own. Not one. Abrupt withdrawal from benzodiazepines can cause seizures. Sudden changes to antipsychotics can cause rebound psychosis. Even stopping a PPI cold can trigger acid rebound worse than the original problem. Every change must be made gradually, carefully, under medical supervision. Fourth, if you have a parent or a spouse or a friend in a nursing facility or assisted living, ask to see their medication list and ask the staff specifically whether any antipsychotics are being given. You have the right to know, and your question alone can change how that facility approaches care for your loved one. Fifth, write down how your memory feels right now. Note the specific things that trouble you, the names you cannot retrieve, the conversations you forget, the tasks you start and abandon halfway through. Write them down so that in 3 months, after a medication review and any changes your doctor makes, you have a clear comparison point to measure whether the fog is lifting. The brain you have right now is not necessarily the brain you are stuck with. If the cause is chemical, the solution is within reach. And the only step between where you are today and where you could be in a few months is a single honest conversation with someone who can look at your medications and add up what nobody has added up before. That conversation could give you back years of clarity that you thought aging had taken for good. Do not wait for the fog to get thicker. Start this week.